Well, this conference is aiming at the fact that most fistula surgeons work isolated. And this is to share our experience and to come up with new techniques, new strategies to reduce the number.
About 60% of the women in Kenya deliver at home. And after prolonged labor, when the baby is not able to come out, that's when they get the damage. Only about 40% of the women deliver in a hospital or in a facility where they can get assistance. And this is where the fistula comes in.
Fistula itself has a social stigma to the patients. You find somebody, a grown-up who is leaking urine, ends up smelling urine all over.
Fistula is, by definition, an abnormal communication between the urinary bladder of a woman and the vagina.
Yeah, in Uganda, like in most other African countries, the prevalence of fistula is not known.
So we have the highest maternal mortality rate in the world. If we are not the first, yeah.
Women mortality and women fistula problem and all the concern of women regarding their health issue is very poor in our poorest countries, let's say Africa and also Asia.
Back home in the UK, the only fistulas we do see really are we don't see very many at all, but are ones that are caused by surgery or cancer or something like that. We rarely see the fistulas that are associated with obstetric problems at all. And you come to Africa and you see a totally different side of things.
I want to believe that Isofs as an organization should come up with policy and guidelines to advise governments on how to prevent obstetric fistula.
I want to share with you this morning our experience, and I'll give you one case study where you engage communities in solving a problem like fistula. We all know fistula is a very common disease, and as such, you can actually map the region geographically where most cases happen in most countries. And as such, you need to start creating communities of practice. Either people who suffer fistula, their leaders, both religious, political authorities, the health workers around those communities, so that you can actually address the problem. I realized with satisfaction, the goal I saw is really towards elimination of fistula. But that will not be possible if the surgeons continue to stay in the hospitals and not engage in the community in the work, in the fistula work. In Amref, we have three themes in the work that we do, or three pillars. Capacity building, which is basically where our fistula work falls in. We have another pillar called community partnership or community partner. And I'll just take you through what we understand by community partnering, so that as you go through this theme in your conference, you start realizing and reflecting on the work that you're doing out in the field. Our definition of community partnering as it is today is really the way that you can get two or more groups of people coming together to solve a common problem. And in case of Amref, these are community groups, either health facility committees, CDOs, faith-based organizations at community level. You need to organize them for a cause. You need to engage, right? And you need to identify the problem with them, in this case, fistula. But everything has got guiding principles. I just wanted to remind you about the guiding principles of any partnership. Yeah? There are ground rules that must be set beforehand and must be followed. We must understand and know each other. We at Amref, we pride ourselves that we understand the communities that we work with. You must have very mutual respect and trust. You must be accountable. accountable to one another, and you must recognize community participation is key. So going out to outreach hospitals and operating without involving the communities and beneficiaries is really not enough. Basically, that's the hypothesis today. You must be clear in your decision making. When you decide to reimburse transport or food or hospital cost, exactly what do you base your decisions on, right? And you must be ready to adapt and change.
Yeah.
This is some snapshots from one of our projects that we're implementing in eastern Uganda. And this tells you some parts of community getting involved. Children, women actually creating awareness about our problem. And that's a school. You wouldn't believe it. That's one of the schools in that part of the world. Why then do we need community partnering? It's one of the bottom-up approach which has been applied in the past to address social underdevelopment and healthcare system weaknesses, which you all know. One of the biggest determinant of fistula is really healthcare system weaknesses. It employs community participatory designs in the sense that you involve the community through the project cycle, from design, implementation, monitoring, evaluation. It actually adds value in many ways. It's a value-adding activity. Don't think it's a waste of time and resources, because you get complementarity. That there are some activities already happening at the community and the health facilities that you're operating. You also leverage resources because there are resources. We all know that 50% of their care, particularly in Kenya, is out of pocket. It's paid from out of pocket. It's not paid by the taxes that we pay, right? And it helps, community partnering helps to integrate primary health care. As you partner with community, you're able to identify risks, because there will be risks, and you plan a contingencies, and ensure sustainability even when you're not there. The respect is based on human rights. The principles, the Universal Declaration of Human Rights, you all know that people have got the right to be heard, their voices must be taken into account, and their fears should be included in whatever we're doing. You need to be sensitive of the culture, that cultural and social determinants of the people where you're working with, whether technologies that you're applying are appropriate, whether your strategies are good for those people. You must be addressing priorities. Let the community set priorities. We might go to a hospital, say Moyale, and say we want to do fistula repair, but their priority is malaria. So obviously you'll be working cross purpose with the community. So whether you're dealing with fistula and malaria, is probably, if you deal with fistula and malaria, then probably you have better results. I think community partnering really supports transformation of communities in the sense that we know still less than 40%, still less than 50% of women are still delivering at home in this part of the world. Why are they still delivering at home? We need to change that. We need to change so that women deliver, whether at home or at a health facility, but with a skilled attendant. That's fundamental to eliminating fistula. You must also recognize that people out there, they are not uneducated, as we tend to call them illiterate. They have indigenous knowledge, which must be tapped into our work. And very briefly, there are 4 levels of community engagement. It can be community, it can be community with the regional authorities, and it can also be community with the global community, as you know. Very quickly, if you are to do it all over again, if you are to go to a community, say in West Pokot, where fistula is a big problem, how do you do it? There's something called community entry. You must consult with the community leaders. It's an extensive process. I know surgeons don't have time to do that, but you can identify a partner who can help you at the grassroots level, who can help you do that. You must get everybody on board, the government, the community structures that are existing on board. You must start with an needs assessment. A lot of time we claim we don't have data on fistula because we never set to reflect the importance of data, particularly baseline data. You must map resources. And at that same time, you'll be able to identify potential partners and engage them. Then you can design the interventions, right? And then as you move along, you start implementing interventions. You reflect, modify as necessary. You learn, you document, you record, and then eventually you have to exit. We'll not be in this forever. If we're going to eliminate fistula, 50 years down the line, we'll probably be exiting in most of our work that we do at the moment. Then, several years ago, you can go and check whether you made any impact. I'll share now very quickly a case study in Uganda. It's called Katini Community Partnering Project, implemented by Amref. As I said, it's in Soroti, eastern Uganda. These people, well, this project, we followed extensive consultation with local authorities, and they identified 3 areas: education, health, water sanitation, livelihood, and community capacity. And this project, we are partnering with Guardian of UK and Barclays Bank and others. We're able to address those 4 priorities at the moment with very good results. So as I say, there are several processes that must be followed, and consultation. We agree on the responsibilities, we sign MOUs, we agree, we continue advocating the communities and also the government as we feedback from the lessons that we learned. What have we achieved so far? It's an inclusive process. People are the center of the decision making, not us. It's not really about us, it's about them. And we should give them that role. We can learn a lot from communities. We assume that we know it all because we've been in school for 20 years, and so we've learned a lot, but they have been also around for a long time. Consulting with the communities and engaging them and putting people at the center of our programs, of our interventions, ensures that there's full ownership of whatever we're doing. And without ownership, there's no sustainability. It reduces the cost of engagement. For example, you can agree upfront that you meet them in the middle, you co-share. These are very poor people, but they're families, and they're villages, they're communities, they're political leaders. Sometimes we do what we call a rambi here to raise money for such a thing. This is a debilitating problem. So communities are willing to come together and raise money to help these people get treated. As we partner with communities, not only we empower them, we also increase their capacity in terms of project design, project implementation. And that enhances sustainability. Ladies and gentlemen, that's all I wanted to share with you this morning. I hope I made some sense. Thank you very much.
I'm going to present on 2 aspects of a study that we did on behalf of the UNFPA and the Ministry of Health here in Kenya, looking at whether community midwives make a difference in improving maternal care. So the first one is looking at aspects from the community. We did some focus group discussions with women in 4 districts in Kenya. The reason why this study took place is because health facility deliveries have remained static over the last 10 years. It still remains 43% in the last DHS that was finished finalised earlier this year. Skilled attendance rate is very different between urban and rural areas. In the urban areas we have a 75% skilled attendance rate, but in the rural areas it's only 37%. There are a number of intangible cultural factors, and patterns of care-seeking behaviour cannot purely be explained by access or awareness barriers. Behaviour and decision-making are motivated by multiple variables that operate within the localised understandings of health and illness. The objective of this particular component was to understand community perceptions around maternal care-seeking behaviour in rural settlements in Kenya. We had 4 focus group discussions in each district with men and women, and the districts were Nyandarua, those 4 districts, Nyandarua, Kilifi at the coast, Taita Taveta and Wingi. The researchers requested discussants whether they could use tape recorders to record the discussions, and tapes were translated from the original languages into English and transcribed, and then the